Hi, Robert Lee here. This is a brief video on radiotherapy following radical prostatectomy, adjuvant versus salvage. To begin, let's define some terms. To my way of thinking, adjuvant is when therapy is given when you have no evidence of recurrence. And in this context, adjuvant essentially means an undetectable PSA. Well, that's straightforward enough. Unfortunately, the test has become more sensitive through time, and undetectable means different things at different times. In the 1990s, the level of detectability was 0.4. Early 2000s, that fell. Late 2000s fell further. And now we have 2 significant digits at Duke, and some even have a supersensitive test. So the meaning of adjuvant has changed, and people use adjuvant versus salvage differently. So to my way of thinking, adjuvant is when you have no evidence of recurrent disease, an undetectable PSA. We have pretty high level evidence looking at post-prostatectomy radiation therapy, and we'll go through those now. We have 3 adjuvant trials. I put adjuvant in scare quotes because, as you'll see, in 2 trials, some of the men, in fact, had a detectable PSA, which wouldn't qualify as adjuvant. First study to be published is the SWOG study. This included more than 400 men with either seminal vesicle involvement or extracapsular extension or a positive surgical margin. Notice that a third of these men had a detectable PSA immediately after radical prostatectomy, which in general is a very bad prognostic sign. They were randomly assigned to immediate radiation or observation. The primary endpoint was metastasis-free survival. Halfway through, they actually rewrote the endpoint because patients were doing better than expected. Nevertheless, here's the primary endpoint showing that the adjuvant arm did better than the no adjuvant arm with regard to metastasis-free survival. Now, I hasten to point out that the majority of the men on the observation arm never received radiation. So this is essentially adjuvant radiation versus no radiation. So early salvage was a small component of this. Most men, 70% we estimate, received no radiation ever. It did result also in a difference in overall survival. A very similar study, the URTC study done in Europe, similar eligibility criteria, much larger, now 1,000 patients. 10 to 12% had a detectable PSA, so that's a lower number than the SWOG study, so these patients are more favorable. A similar randomization, immediate radiation versus observation. The primary endpoint was freedom from biochemical recurrence, but in this study, there was an effort to do early salvage radiation. So most of the men in the wait-and-see arm who developed a biochemical recurrence got pretty early radiotherapy, such that there's no evidence of an improvement in survival. In fact, the men who initially were treated with observation did a little bit better, although it didn't reach statistical significance. The final study is the German study, which is true adjuvant in the sense that patients were required to have an undetectable PSA to go on the trial. So this is a pure adjuvant study, immediate radiation versus observation. Biochemical recurrence was cut in half, but there's no difference in overall survival, distant metastasis, or any of the other more important endpoints. Notice that even with an undetectable PSA, by 10 years in patients with extracapsular extension, nearly half of them developed biochemical recurrence. So putting these 3 studies together, there's some consistencies. The hazard ratio for reducing biochemical recurrence is about the same, somewhere between 0.4 and 0.5. But remember that these are very different populations. The SWOG study included men with the most advanced disease. A third of them had a detectable PSA immediately after surgery. suggesting micrometastatic disease. AUA and ASTRO had put together a guideline in which they state that physicians should offer adjuvant radiotherapy based on the results of these studies. As you'll see, I don't agree. We also have two studies looking at, I think, the more important question, which is adjuvant versus early salvage. What's happened is people have fallen into two camps. Those that favor adjuvant radiation believe that we may lower the risk of cure if we wait for salvage radiotherapy, and others who favor early salvage are worried about unnecessarily irradiating men. Now, before I show you the results of these two studies, be cautioned that they have yet to be published and that all I have are slides which have been gratefully received and thankfully given by the principal investigators of the two studies, the Radical study and the RAVE study. The Radical study is Chris Parker's study, basically patients following prostatectomy whose PSA becomes undetectable. They have high-risk features, and the timing is adjuvant, pure adjuvant radiation or salvage radiation, which is given early, as you can see there. Here are the baseline characteristics. 1,500 men roughly accrued, very similar across the treatments. Most of the men have extracapsular extension. 2/3 of the men have positive margins. 20% of the men have seminal vesicle involvement. Looking at biochemical progression-free survival, there's no difference between the arms. And most importantly, freedom from non-protocol hormonal therapy, that is, salvage hormonal therapy after radiation, whether it's done adjuvant or early salvage, no difference. Chris's conclusions then, there's no improvement in biochemical progression-free survival or further salvage hormonal therapy with adjuvant radiation. He does admit that longer follow-up is required to look for primary outcome measures of distant metastasis and survival. There was increased toxicity seen in the adjuvant radiation therapy arm, and he believes these results support the use of early salvage radiation for PSA failure. As we've said again, those who believe that earlier might be more effective versus those who want to avoid unnecessary treatment. The other trial is the RAVES trial, very similar to Radicals, basically high-risk features, undetectable PSA, adjuvant radiation versus early salvage when PSA is above 0.2. Basically, the Data Monitoring Committee dropped the F-bomb, said that there was futility, and they were never going to be able to tell the difference between the arms, so they recommended closing the study after 333 patients have been randomized. These are the early results. No difference in freedom from biochemical failure. No difference in local, regional, and distant failure, although there's been very few events on each arm. So based on these data, it's my opinion that early salvage is equal to adjuvant radiotherapy, and I recommend in general waiting until the PSA becomes detectable and then early using salvage radiation. Here are the resources. Thank you.